So welcome to the second McKesson touch base. So here's the results from the survey. So this was a scale out of 10, with 0 being not confident and 10 being the most confident. We had about 10 people answer the survey. The results were pretty similar. Lifestyle and screening confidence was at 5.2. Medications and insulin was at 5.8. For most people, the lifestyle and screening, the answers were pretty similar together, between 4 and 7, but the medications and insulin had a really big variance. A few people at 1 and a few people at 8. So hopefully we can increase that. I'll be giving a post-exam survey, and I would really appreciate it if you could fill that out. Yeah. So some other comments from the survey is that you want to select lots of medication options, select the best treatment, as many practice exam questions and there are lots on my exam. And yeah, insulin regimens, dose equivalents, we'll be talking more about that when we review the medication chapter. So we had a case from someone. I'll give you just a second to read that. That is a tricky case. But I want to just pose some questions, and just only 2 people here, so one of you will just answer. There's no wrong answers. There's no I don't have this case figured out, but it's just something to generate discussion, basically. So my first question poses: do you think this person has type 1 diabetes or type 2 diabetes, or what factors would push you towards type 1 and which factors would push you towards type 2?
My gut feeling would be type 2, but I've had a similar patient, type 2, with exactly the same issue, about the same age.
Okay.
And was fairly skinny, was on Ozempic, and the doctor didn't want to start the insulin yet. And I was very surprised because for the last 6 months, he wasn't able to get down on his A1C. So could also be a LADA, but unclear for me.
Yeah.
My guess would be type 2. That's I would guess.
Yeah, I would go with type 2 as well. Yeah.
Yeah, so I would say the age would push it definitely towards type 2. Oops, we've got another person to admit. A whole bunch of people coming in all of a sudden.
I think it's a change in the timings. We are that's why now.
Oh, okay.
Earlier it was a bit late for Ontario.
Oh, what time? Is it 7 in Ontario now?
So last time when we had the meeting, it was around 7:30, and now it's 7. So.
Oh, okay, I see.
Yeah, because of the daytime changes in March.
Oh, okay.
Yeah.
I see. I'll try to keep it consistent from here on in. Yeah. Hi, Negan. How are you doing? Yeah, it's just a small group, so feel free to turn on your cameras and turn on your unmute yourself if you want. Hi there, Amanda. Okay, so yeah, so I would definitely think so the age would definitely push it towards type 2, maybe LADA. The very skinny part pushes it towards type 1. It's kind of unusual to have a person so skinny with type 2 diabetes because insulin resistance is a big part of type 2. But overall, the picture I would say is type 2. And so second is that I would be wondering how she's monitoring her blood sugars. Like when she says that Ozempic and insulin increased her sugars, that's hard to believe. Like maybe she wasn't just at a high enough dose, or she was just testing sporadically and she noticed a high sugar one time when she was on insulin. It's hard to believe that like sustained basal insulin therapy would worsen her sugars. And then another thing would be to wonder is, what's her target? She's 70 years old. Is she frail? If she is frail and has had previous heart attacks, maybe her A1C target is 8 and we don't have to change much. But if she's like this healthy, fit 70-year-old, still active, then yeah, I would aim for an A1C of 7. Maybe she does have 20 years left, so we want to keep those as healthy as possible. Okay.
I had a similar patient this week.
Okay.
That we also discovered something funny. The guy was injecting his Lantus every 3 days. So
Interesting.
it is actually, the nurse and I were very surprised because we all take for granted that he was on that on a regular basis, but actually he wasn't. So
Yeah, it's funny, like these things like to us, it seems like it's so obvious that you take it once a day, but to patients, like they hear stuff on the commercials, like, oh, this insulin lasts 42 hours. So, oh, I can only take it once every 42 hours. Or isn't this the same stuff as that once weekly thing? So, oh, I just have to take it once weekly. So yeah, good catch there. Okay. So we're going to do a very short review of these chapters. Chapter 1 and 2, we don't really need to go through. They're just filler stuff. So let's go right into chapter 3. So something you can do at a pharmacy is that, lots of people don't go for yearly physicals. Doctors often forget to screen for diabetes, and unless their A1C is really high, sometimes doctors won't even mention anything. Like for me, working in a doctor's office, sometimes the doctor doesn't mention that, hey, you have prediabetes, or hey, your A1C is over 6.5. It's not until their A1C gets above 7, it's like, oh, I have to do something about that, that they mention it to their patients. So checking their A1C on, like in Alberta, we use Netcare. I believe in Ontario, you have a similar online lab thingamajiggy.
We are getting into it. I think not a lot of pharmacies have access to the clinical viewer from the Ontario government. We are in the early stages, to be honest. It's kind of like all over the place.
Oh, geez. Okay.
Yeah. So it's unless if the doctor's office are pretty nice, or the patients himself are very thorough with the reports, we get to know their A1C. Otherwise, it's very difficult just to guesstimate,
For sure. Like you can't guesstimate your A1C. Yeah. Okay. So it's just something to mention that, like, especially if they're on statins or ACEs, they're at higher risk for diabetes. And, you can begin the discussion with like, hello, did you know that 1 in 10 Canadians has diabetes and those rates are rising? That's just according to guidelines. And, do you want to know some things you can do to maybe reduce your risk? So remember that discussing diabetes care with people who are at risk for diabetes counts as your 800 hours. So if you're still looking for hours for writing the exam, just talking to people at risk of diabetes does contribute towards that 800 hours. So the next thing you can do is that you can ask them to fill the CAN risk tool. You can print these off, put it in don't get them to do it in your pharmacy, but just, slip it into their bag or something like that. Tell them to, hey, fill this out, bring it back to me. And this is what it looks like. And so people get different scores for different things, their ethnicity, weight, stuff like that. You can do it in a store if you want, or you can just, if it's really busy, I know with vaccines and COVID, it's been super busy. You can just slip it into a prescription bag and get them to bring it back to you. So once they fill it out, they'll be given a risk score. And this has a percentage chance of 1 to 17, 33%, 50 plus of developing diabetes. And I think it's great that you can individualize it and tell them, hey, Mr. Smith, you've got a 50% chance of developing diabetes over the next 10 years. Do you want to do something about it? Because there are lots of things that we can do about it. Things like dietary changes, physical activity, even if you've got prescribing, I think that's in the works at different provinces. You could maybe even consider starting them on metformin. So there are various things that we can do to help them prevent the conversion from prediabetes to diabetes. Healthy lifestyle behavior interventions, it's a big 58%, and there's no side effects with that. And when people hear that, oh, wow, that's not like, oh, if I do all this exercise, I only get a 10% reduction in my risk. Why bother? It's hard to motivate people to exercise and change their diet. But if you tell them, hey, you can get almost like a 60% reduction in your chance of becoming diabetes, I think patients really you really will be really wowed by that. Yeah. So lots of things we can do. So this is from the Diabetes Canada guidelines. Oh, hey, hi, Jane. Bless you, Jane.
Oh, sorry.
Yeah, don't worry. You don't have to mute yourself. I want people to ask questions. Where was I? Yeah, so this is from the Diabetes Canada website. And this is great because, you know, people hate going to the gym. People, especially if they've been overweight their entire lives, they view it as very judgy, and it doesn't feel very comfortable. And so you want to make physical activity comfortable and fun. You know, trying to motivate myself to exercise is difficult. So, you know, you want to try to make it as easy as possible. And I really like this this exercise routine. You can do it with resistance bands, and you can just buy resistance bands for cheap at Amazon. I'm not sure if McKesson sells this stuff. If so, please buy through McKesson. But you can look on Amazon. You can get a 50-yard roll for about $100. You can also look for sales too. So I've gotten these for as cheap as like $90 if you kind of check back once in a while. It's 50 yards, 1 yard per patient. It's less than $2 per patient. You know, patients really appreciate it when you show them this thing and then you give them a band. It's like, okay, why don't we do some together? Maybe if you're at a really busy pharmacy, that doesn't work, but you know, you can show them maybe like one exercise or two exercises. It gets them thinking like, oh, hey, I could actually do this. You know, if their spouse is in there, try to get both of them doing it. Usually, if you ask one person to do it, they never do. But if you get it as a group exercise thing, it's more likely that'll stick. There's also a video online as well that walks you through this. It's on my website. You can just give them the video. But yeah, patients have really appreciated it when I've given them a band. I've probably done this with patients probably I'd say 2/3 of my patients. I go through this and they enjoy it. Not everyone does actually make a habit of doing it, but at least, you know, you're making an intervention and they appreciate it. They'll feel, they never see it as, you know, you failing to convince them. They see it as, oh, sorry, Esmond, I failed to do those exercises that you gave me. So just gently encourage them. And yeah, I think it's something that we as pharmacists can really have a big impact. Trying to find videos and stuff like that is great too. You know, I used to watch these participation commercials when I was a kid, and I'm kind of surprised they're just still around. But they have a variety of high to low to high intensity home exercise videos that you can recommend to patients. Patients enjoy just, you know, exercising at home in the privacy of their own home, just something fun for them to do, and you know, it doesn't cost them anything. And in terms of dietary changes, I think the easiest one to go for is to try to get them to stop having high glycemic index carbs. And that's something, you know, I don't know how many of you guys have like kind of grocery stores or snacks attached to your pharmacy, but this is something where, hey, if you do have a lot of if you are attached to some food place, get your patients to come by and say, hey, which ones of these are low glycemic index? Which one is, these are high? You know, tell me what is good for me. And I think patients would really appreciate that. And again, you're trying to tell them that, hey, you can get a 60% reduction in your risk of going from pre-diabetes to diabetes. So let's say, Mr. Smith, your risk was 50%. With these changes, we can get you down to 20%. That's a big difference. So yeah. Okay, so chapter 7 is the self-management, education, and support chapter. You know, it's a Prochaska model, trying to support patients to, you know, move them from contemplation to preparation. You know, you should tell patients that you expect people to relapse. No one's a perfect patient. You've never had a patient that's, you know, exercises 100% of the time exactly as you prescribed it. No one eats healthy 100% of the time. In fact, I get suspicious if someone tells me that. So yeah, just try to be supportive, and, you know, tell them to expect relapse relapses. When you do have a relapse, don't beat yourself up over it. Just try to get back onto the wagon as soon as possible. Okay, targets. So, often patients don't know what their targets are, and they don't know how to interpret it. And, when they don't know what the numbers mean and what to do with them, they often feel like it's a waste of time, it's painful to prick your fingers, and it's expensive. So they feel it's like a waste of time, pain, and money. So reminding them their targets and letting them know how to interpret it can be really helpful. For most people, it's 4 to 7 before meals and 5 to 10 2 hours after meals. And try to give them ideas on what to do if those readings are out of range. So for example, if your sugars are below 4 and they're hypoglycemic, let them know what the symptoms are. We'll talk more about this at the hypoglycemia chapter, but sometimes people don't know what the symptoms of hypoglycemia are. So then people are like, oh, so that's why I feel shaky and dizzy before meals all the time. I'm going low, or my insulin is my doctor prescribed insulin that was the dose that's too high for me. So review those symptoms, and if they're low, standard treatment is 15 grams of fast-acting carbohydrate, honey, sugar. You could sell them Dex-4 tablets. All of that works. And then for high sugars, for most people with type 2 diabetes, you don't have to worry about DKA unless their sugars are extremely high and they're extremely dehydrated. So most of the time for type 2 diabetes, you can just recommend that they drink a glass of water and go for a brisk 15-minute walk to bring their sugars down. For type 1 patients, that's a little bit more tricky. They go into DKA more easily, and so you might need to bolus them. But if their sugars are not too bad, like if it's like below 13 and they're high, you could just recommend drinking a glass of water and going for a brisk walk. All right. Also, this is easier if you've got access to their labs, but remind them that, hey, when was the last time you went for an A1C? This is your target. We're aiming for this. Oh, hey, Mrs. Smith, you're, because of your age and your frailty, we're not aiming for 8. 8 would be reasonable. And or Mr. Smith, your A1C is targeted at A1C is 7. So you're not quite there. We want you to work a little bit harder with your lifestyle changes, or that's why I'm increasing your insulin a little bit. We want you to get below 7 because that minimizes the risks of diabetes. Okay, so monitoring glycemic control. So just to review how to use blood glucose meters. There's various apps that are attached to them now. The One Touch Reveal app is really good. The Libra app is very good. Those are the ones I use all the time. Just review how to use them. Review the frequency of how often they have to do it. If the patient's on metformin and they're stable, they don't have to monitor 4 times a day. You can look at Appendix 5 of the guidelines, and I'll give you an idea of how often to recommend blood glucose monitoring. Okay. And then a trial with a continuous blood glucose monitor combined with food and exercise diary is really helpful for patients. When they have a continuous glucose monitor, they can see that, hey, when I eat this pizza, oh, wow, my sugars really go up. Or, hey, that exercise you told me to do, when I do that exercise, I really see my sugars go down. Like sometimes they need to see the numbers change for them to believe you. And something really good to do is you can actually order some samples for yourself as well, so that you could try putting it on and experimenting of, oh, hey, this juice does really make my sugar go up. I should mention that to my patients, or this exercise works best for me. So I know that the sensors are expensive, but you can actually both healthcare professionals and patients can use this website and get a free sensor. You can also talk to whoever your local rep is and try to get some sample sensors as well. To be honest, at my clinic, I go through sensors like water. I get like 30 sensors in per month, and we go through them like probably in a couple of weeks need to order more. So yeah, if you're interested, you can try this program. Healthcare professionals can join. There's no problem with that. If you've got a patient who's, just really stuck and not sure what exercises or what diets are really affecting their sugars, give this a try. It's a free trial, and then you can help them change their sugars. And so you can also consider setting up a database of your own patients. So if they use the Libra app or the One Touch app as well, you can actually set up a database where it actually uploads onto your cloud. So here's an example of LibraView. Here are my patients. And when I have something like this, I can see, okay, this guy here is, 43% in range, second from the bottom here. That's the guy I need to call to see what's going on. Like this person who's 97% at target, I'm probably not gonna call them. And I've got a 19% person, only person who's 19% in range, and their average sugar is 14. So that's the person I definitely need to call. And this is just a way where you can touch base with patients and really keep track of them. To be honest, I've never seen a doctor use this. So this is a service that I think as pharmacists, we could really provide, and patients really enjoy. You do need to be set up with this. You need to set up a clinic code and all that, but that's really easy to do. I do mention this a little bit in my update to the blood glucose monitoring chapter, but we'll go through this more later. Okay, so physical activity. So for physical activity, the probably most important number to remember is the recommended amount is 150 minutes per week. A combination of resistance and aerobic exercise seems to work best. And try to see what's available in your local area and try to make it a social activity for patients. That seems to help them stick with it and make it more fun. So a website that I recommend is meetup.com. And so what that is, it's a website that, let's say I had an interest in hiking. So I would just set up a group for hiking and people would join my group and we'd go hiking. There's, as you can see here in Calgary, there's slow and steady hikers, Calgary nature lovers, anything but couches. There's there's a group for everything. If you like Dungeons and Dragons, there's tons of Dungeons and Dragons group. If you like crocheting, there's a group for that. If you like Toastmasters, there's a group for that. I think that if not for the physical activity, just the social activity of just seeing faces, especially after COVID, is really helpful for patients. So just check out what's in your local area and then go from there. Okay, so in conclusion, I think that there are several impactful interventions that you can do for your patients in a pharmacy setting. The reminder that the exam is 9 weeks away. Next time we'll review chapters 11 through 20 at our next touch base meeting. The Q&A session with Dr. Seuss Peterson has been scheduled. Just look at my important updates for that. I just got an email from Dr. Peterson that she may need to move that date, but tentatively it's for May 11th. My Q&A is on May 25th, and that's unlikely to change. And yeah, just want to open it up to any questions or cases that people want to share. Okay, wonderful. Bianca, are you still here? Did you want to mention anything or anything like that?
Thank you very much, Esman. I'm surprised there is no question. It must be because it was clear. So
okay.
Much. It was very interesting and well structured. So thank you. Someone have a question. We listen to you.
Oh yeah, Negan, just unmute yourself. Ask your question. Hello? You're unmuted, but I can't hear you.
It's strange.
You are unmuted, Negan, but none of us can hear anything.
Do you want to type question?
Yeah, just type it in the chat and I'll just answer it. Are there select all that apply questions? Oh, so on the exam. Yeah, there could be some questions on the exam that are like all of the above and stuff like that. That's possible for the exam. There won't be any like, there used to be a lot of like A and B or C and D or like C, D, and E questions, but I think they've gotten away from that. So I have seen some like select all about all the above questions, but I haven't seen any of those like K-type questions. Perfect.
Thank you.
No
Do
problem.
you have another question?
No, it doesn't seem like it.
Great, Bayan, thank you. So will you send us a reminder with the link for the next meetings?
Yep, I will. I'll have to look at my schedule and see when to put it, and then I'll send you guys another Zoom link just like this. I'll make it for 5 o'clock.
Perfect. And we have the schedule until the exam. That's perfect. Thank you.
Yeah, wonderful. Okay, I hope you guys have a wonderful day and good luck studying.
Thank you, Esmond. Have a great one.
Thank you.
Have
See
a
you
great
later.
evening. Bye.